So while they're getting set up, I'll introduce my colleague, Brent Hanks, so also a medical oncologist who focuses a little bit more on drug therapies for melanoma, and that applies to sort of different stages of melanoma. And tonight he's going to talk with you about some of the advances in immune therapies and some of the side effects and how to manage those. Thanks, Brent.
So I was asked to discuss toxicities and side effects associated with immunotherapy. And I'm just going to launch right into that. As many of you know, immunotherapies have really revolutionized the management of advanced melanoma. And this slide just shows the differences in overall survival for patients with stage 4 melanoma pre-2011. This was prior to the FDA approval of Ipilimumab in 2011. That's Yervoy. With subsequent years, we've been able to improve those survival numbers with the availability of these immunotherapy agents. Clearly, Ipilimumab has shifted that curve in a positive manner. We have the more recent availability of these other agents referred to generally as the anti-PD-1 antibodies, which of course includes Nivolumab or Opdivo, as well as Pembrolizumab and Keytruda. Further improving survival numbers for patients with advanced melanoma. And then finally, we have the combination of Ipilimumab and Nivolumab, which has shifted those numbers a little bit more. So overall, significant improvements in the management of patients with advanced melanoma. But of course, these therapies do come at a cost. As I mentioned, the whole point of this talk this afternoon was discussing the side effects in management of those side effects of immunotherapies. But these immunotherapies can cause side effects that can involve any organ of the body. And many of these symptoms associated with these side effects are very similar to what we see in autoimmune diseases that also affect those same tissues. At this point in time, we do not have a marker, unfortunately, that can predict the development of these side effects and toxicities, but there are promising research that in the coming years we should have something to try to lead us in the right direction and improve our management of patients with these diseases. So when the immune system recognizes a tumor in our body, we have these cells called antigen-presenting cells that can uptake these antigens that are derived from the cancer and can eventually make their way back to our lymph nodes. And when they travel to the lymph nodes, they are able to induce, or they interact with T cells in our immune system, and they induce the activation of these T cells that occurs in the priming phase of the immunity cycle. Those T cells, once they're activated, they're able to migrate out of those lymph node tissues and eventually make their way back to the tumor and hopefully destroy the tumor cell itself in the effector phase. So you heard me mention the drug Ipilimumab or Yervoy, and that drug tends to primarily affect the priming phase of the immune cycle. And that drug in and of itself is associated with depending on where you look, between 30 to 50% grade 3-4 side effects or toxicities in patients. And then you heard me mention the anti-PD-1 antibody agents, either Pembrolizumab or Nivolumab. These drugs tend to have most of their effect of the effector phase of the immune cycle, and in phase 3 studies have showed approximately 15% grade 3-4 toxicity. So overall, these anti-PD-1 antibodies, which are really considered first-line therapy for many situations in advanced melanoma, these agents are associated with improved side effect profiles, lower incidence of toxicities that tend to be milder. So some of the more common side effects that we see in the clinic, certainly toxicities that involve the skin or the development of dermatitis, rash, itching, dry eyes, dry mouth, the colon itself or colitis leading to loose stools, stomach cramping, and fatigue. The thyroid is also another more common toxicity. You can develop a elevated production of thyroid hormone in your bloodstream that's referred to as a thyroiditis that can lead to rapid heart rate, increased sweating, heat intolerance, and also fatigue. These immunotherapy agents can affect other endocrine glands that include the pituitary gland. That's a little less common, but can also lead to fatigue and headache. And then finally, the liver or a hepatitis can also develop. Oftentimes, this does not lead to any notable side effects or symptoms from the patient, but can lead to fatigue and nausea, fever, and night sweats occasionally. On the right of your screen, you see some of the timing of the onset of some of these side effects in response to Ipilimumab or Yervoy. Oftentimes, rash is going to be the earlier type of toxicity that we see. A little later in time, you see the development of a colitis or the loose stools, and then the liver toxicity and the inflammation of the pituitary, referred to as hypophysitis, develops with a little more time. So these are just the averages and timing of development of some of these toxicities and side effects. And that was in response to Yervoy or Ipilimumab, and this is data showing how these side effects develop in time to Nivolumab or one of the anti-PD-1 antibodies. They're somewhat different. They tend to be basically on the same time scale. Generally, the rash will develop earlier on, loose stools a little bit later, but not nearly as frequent with the anti-PD-1 antibody therapies. And then, of course, you get into the endocrinopathies. The side effects that affect the thyroid and pituitary tend to be a little bit later in time. The graph on the right shows you the timing of these development of these toxicities, and is really indicating that if you haven't developed side effects to, in this case, Nivolumab, by a fairly early time point in the first few weeks, the first several weeks, I should say, the first 48 weeks of treatment, it's very unlikely that you're going to develop any side effects any point in time past that. So at approximately 32, 48 weeks, if you have developed a side effect, it's going to be much more or less likely for you to develop a toxicity at that point. So when considering general principles of immunotherapy side effect management, the most important thing is to realize that it's really going to be primarily up to you to tell us what side effects are you developing? What are the symptoms that you're developing that are different to you? What are you concerned about? So open communication between yourself and the clinic staff is going to be very, very important for managing these toxicities, because the earlier we're able to treat them, the better off things are going to be. So I have listed here some questions that we're asking. So I thought that you may be interested to hear, what exactly are we wondering in these situations? Are there other potential contributing factors, like certain forms of infection, that could be leading to some of these symptoms? So we can't just ignore that possibility. Should the next dose of immunotherapy be delayed? Should we hold treatment, or is this more severe, and should we discontinue treatment altogether? Should oral steroids be initiated, such as oral prednisone? This is an agent that we use fairly commonly in managing these side effects. Should we admit the patient to the hospital for IV steroids, IV hydration, IV fluids, or a diagnostic procedure to help us work this out a little bit better? And then finally, should other second-line treatment agents be considered? We have other immunomodulatory drugs that we use for more severe cases of toxicity, for cases that happen to be refractory to steroid therapies. Now, in reference to steroid therapies, I think it's also important to understand that when we manage the side effects and toxicities with steroids, we want to maintain that dose of steroid that we start you out at for at least a week after some symptoms develop, and then consider gradually decreasing the dose of those steroids over a taper, over a period of approximately 30 days. During that period, if somebody is on for a longer period of time, for whatever reason, we also are concerned about protecting you from other infectious complications with prophylactic antibiotics, for example. So a couple of examples of more specific situations that we see. Of course, I mentioned rash earlier as one of the more common side effects and toxicities. As you can see in the table in the upper left-hand corner, Yervoy itself, or Ipi, tends to certainly be much higher incidence of rash compared to our anti-PD-1 antibody therapies, just from a sheer numbers standpoint. For low-grade rashes, these rashes it can take many, many forms, and there's different types of rashes that I think are more becoming, just now becoming to be realized to be associated with some of these agents, matter of fact. So for low-grade rashes, we tend to continue immunotherapy, so we don't let that interfere with your treatment course. We consider topical steroid therapies and then also some oral antihistamine agents to help you with the itching. For more severe rashes, such as grade 3 rash, we do hold treatment at that point and then start patients on oral steroids like prednisone, and then again taper over at least a month period of time. And then with more serious rashes, we will hold treatment altogether and discontinue your therapy altogether. So inflammation of the bowel or colitis can develop, as I mentioned earlier. That is one of the more common side effects that we see, and I think it tends to be sometimes the more problematic. Yervoy or Ipilimumab is responsible, again, for the majority of these toxicities, although it can occur in the anti-PD-1 antibodies. It's not nearly as frequent. Pathologically, this colitis really resembles inflammatory bowel disease to a significant extent. And in a very small percentage of cases, it can lead to bowel perforation. So we don't take this lightly. We need to manage it quickly and thoroughly. In terms of our management, low-grade colitis, we will often continue immunotherapy in those situations. We consider over-the-counter drugs like loperamide, Imodium. Grade 2 colitis, this is really based on the number of stools that can develop in a 24-hour period primarily. We will hold treatment. We want to make sure that there's no infectious causes that could be leading to these symptoms. And then we will start someone on oral steroids. And then finally, with more severe colitis, then we will permanently discontinue treatment. We admit the patient to the hospital for IV steroids, IV fluid hydration, and even consider other immunomodulatory biologic agents that may be more effective at controlling these symptoms. Now, we also mentioned that you can develop a autoimmune hepatitis, it's inflammation of the liver. It's not nearly as common, and it only occurs in around 5 to 8% of cases of Ipilimumab treated patients. Most patients do not have any symptoms, and we detect this strictly based on lab values, some of your laboratory tests from your blood test. This must be differentiated, of course, from viral hepatitis and other drug-related toxicities. And that's not coming up, so I'm going to skip it. But it was just to illustrate, again, some of the management options that we have for the autoimmune hepatitis, which, of course, initially starts out with oral steroids, and then in more severe cases, depending on the level of your liver enzymes, and more severe, you could be admitted. IV steroids are considered, and other immune modulatory drugs, as I mentioned previously. So some of the side effects that we see can actually affect your endocrine glands, like your thyroid gland or your pituitary, as I mentioned previously. The thyroiditis is one of the more common problems that we see. I think it's also important to mention that opposed to other immunotherapy side effects, not necessarily in 100%, but in a majority of cases, these conditions are often permanent. And we can substitute, or we can provide supplement hormone therapies if that is the case. So one of the more common scenarios that we see is the development of a hyperthyroidism, so elevated thyroid hormone levels in the blood. This can last for a few weeks and can result in increased heart rate occasionally, maybe increased sweating in some patients, maybe some weight loss in some. And those levels of the thyroid hormone will go up, and when the stores of thyroid hormone are depleted by the thyroid gland that's being assaulted and attacked by the immune system, then you start to see naturally those thyroid stores deplete, and those thyroid hormone levels decrease and diminish. Oftentimes, in these kind of situations, we will continue immunotherapy. We're not going to hold or discontinue any treatment. We will consider other medications such as beta blockers if there is a rapid heart rate or happen to be development of an abnormal heart rhythm, for example. as I mentioned, we initiate replacement thyroid hormone therapy once the hypothyroid state begins. So we have, again, this transient period of hyperthyroidism that often will transform into a hypothyroid state. And at that point, we'll actually begin thyroid hormone supplementation. And we'll continue to monitor your thyroid hormone levels every 3 to 4 weeks. So the other endocrinopathy that I mentioned, of course, is inflammation of the pituitary. Pituitary is a very important endocrine gland because it controls all of our other endocrine glands. This is just an illustration of how we have a central nervous system structure called the hypothalamus that regulates the anterior pituitary through production of a certain hormone, and the pituitary can regulate the adrenal gland and its ability to produce endogenous steroids such as cortisol. And so, as I mentioned, many times this occurs. It's often permanent, although there are cases, as I mentioned, an example here of the pituitary thyroid axis as recovering in approximately 50% of cases. So when the pituitary is affected, it can lead to headache, which is most common. Nausea, weakness are really going to be the most common symptoms. And when we're concerned about this, we can consider brain MRI, but also blood tests. And blood tests to look at identifying some of these hormones that are produced by the pituitary to see if they are been affected by the immune system, in which case those levels will be low. And that will trigger us to start an oral or IV steroid therapies, depending on how you're doing. And then eventually this is tapered down to physiologic doses of steroids with a drug called hydrocortisone often to replace those levels of steroids that would normally be produced by your adrenal gland. That's going to make you feel a lot better, often very quickly. And we also, of course, are very concerned about the development of what we refer to as adrenal crisis, which is something that develops with increased stress and can lead to lower blood pressures. So hypophysitis in general can be very serious, and we do monitor for this just depending on the symptoms that you tell us about in the clinic on a day-to-day basis. So finally, one of the other toxicities that we do see occasionally is inflammation of the lung or pneumonitis. This occurs in approximately 5% of patients that undergo treatment with an anti-PD-1 antibody, 10% of cases with combination immunotherapies. It tends to be more common actually with anti-PD-1 therapies like Nivolumab or Pembrolizumab compared to our other immunotherapies. The most common symptoms are dry cough, shortness of breath, occasional chest pain, and as I mentioned, and it's not coming up again, other respiratory diseases should also be ruled out, infection, blood clots, things of that nature that we don't want to ignore and miss. But oftentimes we'll order a CAT scan and potentially even consider bronchoscopy. Depending on this level of your symptoms, we will consider either oral or IV steroid use again, and possibly hospitalization depending on the severity of the symptoms. Now, with the combination Ipi-Nivo immunotherapy regimen, you tend to see, many of the side effects are going to be very similar across the board, very similar. They can occur at earlier time points. So what you're seeing here is a graph with time on the x-axis, and the side effects with Ipi-Nivo combination treatment tend to be a little bit earlier in time. They also tend to be a little bit more severe overall compared to either single agent Ipilimumab or Yervoy or single agent Nivolumab or Opdivo. So it's something that we definitely take monitoring for side effects and toxicities, in particular with this particular regimen, very seriously. And I think one of the interesting aspects of the combination therapy approach is looking at the patients that stopped or discontinued their treatment because of side effects. What you see here in this table, complicated table with a lot of numbers, but if you look at the combination treated patients, Ipi-Nivo patients, around 1/3 of them stopped treatment during the first 4 doses of Ipi-Nivo therapy. And that was directly related to the toxicities. But if you look at the response rate in those patients, it's almost 70%. In that particular patient population, that subgroup that discontinued treatment because of toxicities. So since that time, there have been a few studies published looking at the relationship between side effects, toxicities, and response rates. And the data that you see in front of you are all related to Nivolumab or Opdivo. And what you see is that the number of immune-related side effects that develop in patients correlates with the objective response rate that you see in the same patient. And the data on the right is actually looking at overall survival, where the top line is survival of those patients. Those are patients that did develop an immune-related side effect, and then the lower is the patients that did not. And so clearly there's a relationship between the development of toxicities and side effects in this patient population and clinical response. Now, that doesn't mean that if you don't develop a side effect, you don't see response. That's actually not the case, but there tends to be a relationship, a positive relationship there. The other aspect of this that I would point out that I think is relevant, that is if you were taken off treatment during those first 4 doses of therapy with Ipi/Nivo, it doesn't necessarily mean you're not going to derive any benefit. So in fact, as I just mentioned, there's a 70% response rate. Those responses are often durable. So if you did develop a toxicity, a side effect that led your physician to discontinue treatment, it doesn't necessarily mean you didn't get any benefit, and I would say actually just the opposite, that you would benefit from that particular regimen. And then I think another topic at hand that's relevant to this particular presentation on immune-related side effects is, what is the impact of steroid use or other drugs that we use to treat these side effects? What is the impact on your prognosis overall? And there have been studies that have looked at earlier on Ipilimumab related toxicities and side effects, and what the role or the impact of steroid use on the outcome of those patients. And it's a little small, but on the bottom, you see that in those patients that were treated with steroids, they did not do any worse from a response perspective than patients that were not treated with steroids during the course of their therapy. And on the right is relapse, and the degree of relapse was also no different. That was the data that was presented several years ago that related to Ipilimumab treatment. More recently, there have been studies looking at the anti-PD-1 antibody therapies, and recent meta-analysis of 4 independent studies for patients that were treated with Nivolumab or Pembrolizumab. Approximately 24% of patients received steroid therapy for side effects, but there was no significant difference at all in response rates. So it suggests that there's no concern there for diminishment in response or clinical outcome if you ever happen to be treated or require treatment with steroids or other immunosuppressive agents for some of these side effects. So, in conclusion, side effects associated with immunotherapies can include any organ of the body. The most common side effects include fatigue, rash, and loose stools. The incidence of the side effects, you go from left to right, is the lowest is going to be the anti-PD-1 antibodies, Nivolumab or Pembrolizumab, then Ipilimumab, and then beyond that, the Ipi/Nivo combination. It's really important to report any side effects that develop, so open communication with us in the clinic is going to be critical. The management of these immunotherapy-related side effects includes the use of steroids often. Hospitalization may be necessary depending on the severity. Additional diagnostic procedures are sometimes necessary, and occasionally other immunomodulatory drugs are going to be required. We know that clinical benefit overall correlates with the development of immune-related side effects. As I mentioned, however, if you don't develop a side effect, it doesn't mean you're not going to respond. And the use of steroids for the management of immune-related side effects does not appear to adversely affect clinical outcome. And finally, if you do develop a toxicity and you're taken off a treatment, in some cases we'll consider retreating you with either the same immunotherapy drug or a different one, depending on the situation, depending on the severity of your side effect. So with that, I'm going to stop.